Hi friends, I'm Dr. Mayur Kulkarni, and today we are going to discuss the radiology related questions which were asked in the recent INI-CET exams. Well friends, look at this quote. It says that never stop learning. And why is it so? Because life never stops teaching. Now let me add a little bit of a twist to this particular quote, and I'll choose to say that never stop learning because your INI-CET never stops teaching. And this is true for everybody involved in the process. As a student, for you, you're watching this video because you went into this INI-CET exams, you did well or you did not do so well, and now you are targeting the upcoming exams. Therefore, it is important for you to go back to the exam, the questions which were asked, and try and learn what they are trying to, teach you. We look at some important topics because there's a set of topics which is very frequently asked in your INI-CET exams. The same related set of topics is also frequently asked in your NEET exams. So we are going to focus on that. Honestly, let me share with you, even as a faculty, every INI-CET exam does teach us something. It teaches us an entirely new perspective, to look at a particular topic as to how the questions could be framed. Sometimes it draws our attention to topics that we thought would never be asked, but ultimately a question on the same topic lands up in your exam. So it's non-stop learning for each one of us involved in this particular process. So let us begin with the first question, right? And now we are going to first deal with the first session, questions which were asked. So look at this, a very typical match the following kind of a question. So there were various named signs which were described. So football sign, string sign, rat tail sign, inverted umbrella sign, and a list of diagnoses. You're supposed to match them up. Let us look at some important signs. So remember, in your INI-CET exams, GI tract radiology, genitourinary tract radiology is a very, very high yield important topic, right? So this is something that we emphasize in our regular videos as well. For INI-CET exams, somehow, they are in love with GI tract radiology, GU tract radiology. And this was one question which was from the GI tract imaging science. So pneumoperitoneum, very, very, very important topic for your exam. Why so? Because your examiner always wants you to make this particular diagnosis. Your examiner wants to make sure that you never miss this particular diagnosis. Remember, because if you miss this particular diagnosis, right, the patient may lose his life in clinical practice. So therefore, a lot of questions every other year, a question is asked on pneumoperitoneum. So a question this time was asked on one of the signs in pneumoperitoneum. All these signs have been described on supine abdominal radiograph or supine abdominal X-rays. What are these signs? Let us look at a few important ones. When there's a lot of free air in the peritoneal cavity in the abdomen, and in the supine position, the air rises up to the non-dependent part and collects as a huge oval lucency over the central abdomen. This oval lucency over the central abdomen, because of air underneath the anterior abdominal wall, is what is called as the football sign. Now, this air also rises up, reaches the dome of the diaphragm and lines the central tendon of diaphragm from below. This, dome shaped lucency that you see, that is because of the air lining the central tendon of diaphragm from below. This is what is called as the cupola sign. Now, air comes and lines the falciform ligament. Can you see the sharp margin there? It is a water density structure, but when it is lined by air on both of its sides, free air in the peritoneal cavity, differential radiographic density theory creates a sharp margin. That is, the falciform ligament becomes visible as a sharp margin. This is what is called as the falciform ligament sign. Similarly, when free air comes and lines the surface of the liver, the surface of the gallbladder, these surfaces become visible as sharp margins. This is what is your liver or gallbladder edge sign. Air occasionally gets trapped. Free air within the peritoneal cavity is going to line a particular bowel wall from the outside. So the outer bowel surface or serosal surface is going to be sharply demarcated. Similarly, the air within the lumen is going to line the inner mucosal lining. So if you look at a bowel loop, its outer margin as well as inner margin becomes very well visible. When both the mucosal and serosal linings are well visible, this is what is called as the Wriggler's double wall sign. Air occasionally gets trapped within the Morrison's pouch or the hepatorenal pouch. When it does so, it creates an eccentric triangular shape like this cap, and this is what is called as the Doge's cap sign of pneumoperitoneum, right? So the the sign which was mentioned in the question in your exam was this football sign of pneumoperitoneum. Now, as far as the diagnosis of pneumoperitoneum is concerned, classically it is diagnosed on a radiograph by visualizing the air under the diaphragm. See here, can you see this? Free air under both domes of diaphragm. So X-ray is an initial investigation. If your examiner asks you what is the best X-ray or best radiographic projection for detection of minimal pneumoperitoneum, remember it is an erect chest X-ray. Though I am showing you a erect abdomen radiograph here, remember overall best X-ray for diagnosis of pneumoperitoneum is an erect chest X-ray. Whereas if your examiner asks you what is the overall investigation of choice for detection of minimal pneumoperitoneum, then the investigation of choice is going to be CT. So best X-ray is erect chest X-ray. Overall investigation of choice is going to be CT. All right. Now look at this clinical scenario. An 8-week-old baby, so a child, right, who is just 8 weeks old. Remember, this condition is not presenting at birth, but after a few weeks after birth. And the child is presenting with what? Child is presenting with projective or projectile non-bilious vomiting, and there is an olive-shaped mass which is seen and felt in the epigastrium, right? So a 8-week-old child presents with non-bilious vomiting, right, which means that there is some obstruction proximal to the second part of duodenum. Where is the obstruction? You can see the over-distended stomach over here within this barium meal study, and you can see at the level of the pyloric canal is extremely narrow. This is what is the site of obstruction. So what is this? This is nothing but hypertrophic pyloric stenosis, right? Now various signs have been described on a barium meal study. So what is this study? This is a barium meal study. Various signs have been described. What are those? Now see, this is the hypertrophic pyloric muscle, right? So because it is creating an obstruction, the stomach is trying to push the contents distally. So the stomach is hypercontracting. This hypercontractile stomach looks like a caterpillar. So this is what is called as the caterpillar sign. The opening of the pylorus here looks like a beak. So this is called as the beak sign of hypertrophic pyloric stenosis. The muscle, the hypertrophied muscle, creates a shoulder-like impression, right, on the stomach, on the distal body of the stomach, right? So this is what is called as the shoulder sign of hypertrophic pyloric stenosis. The lumen of the pyloric canal becomes extremely narrow like a string. So this was one of the options in your exam. This is what is called as the string sign of pyloric stenosis, and the hypertrophic muscle is creating an impression on the proximal duodenum. Look at the shape of the duodenum. It looks like a mushroom. So this is what is called as the mushroom sign of hypertrophic pyloric stenosis. So all these signs have been described on a barium meal study in hypertrophic pyloric stenosis. Now, can you tell me what is the overall investigation of choice for diagnosis of hypertrophic pyloric stenosis? Though barium meal was used conventionally, traditionally, now the investigation of choice is considered to be, investigation of choice is considered to be USG. So investigation of choice is USG. That is because, right, while the child is sleeping or the mother is feeding the child, you can quickly keep a probe on the infant's abdomen. Pylorus, being very superficial, can very readily be seen on USG. The hypertrophic pyloric muscle is usually seen as a muscle thickness layer of more than 4 to 5 millimeters in thickness, and the overall length of the pyloric canal being more than 16 millimeters. These are the criterions on USG which help us make a diagnosis of pyloric stenosis. USG today is the investigation of choice for pyloric stenosis. Now, ileocecal TB is an important condition. Why? Because it is the most common site of gastrointestinal tuberculosis. So the most common site is the ileocecal junction. Now, the earliest, so traditionally, the study which was done to diagnose ileocecal TB was barium meal follow-through. What is the earliest finding on barium meal follow-through? It is usually the spasm and hypermotility. Spasm and hypermotility at the ileocecal junction. So spasm and hypermotility at the ileocecal junction is considered to be the earliest barium meal follow-through finding in ileocecal TB. When nowadays CT is being more commonly done, so most common CT finding in ileocecal TB is usually mural wall thickening. Mural or wall thickening is considered to be the most common CT finding in ileocecal TB. Conventionally, various signs have been described in ileocecal TB. One sign is what is called as the inverted umbrella sign, and this was one of the options in the said question. What happens in ileocecal TB is that the terminal ileum becomes extremely thinned out and narrow, right? Whereas the ileocecal valve becomes patulous, right? So this patulous ileocecal valve looks like this inverted umbrella, as you can see in this picture there. This appearance is what is called as the inverted umbrella sign seen in ileocecal TB. Now, another sign in ileocecal TB is because of the inflammation and the fibrosis of the mesocolon contracts. As a result, the ileocecal junction is pulled up. Normally, the ileocecal junction should be low down in the right iliac fossa, isn't it? But because of the fibrosis along the mesocolon, the ileocecal junction is being pulled up, right? So this is called pulled up cecum. The cecum lies high up, not in the right iliac fossa, and as a result, the terminal ileum hangs down from it. So this is what is called as the pulled up cecum and the goose neck deformity of the ileum. So inverted umbrella sign is what was there in your question. This is a sign which is seen in ileocecal TB. Yes, now patient presents with dysphagia. You see a smooth, elongated tapering, right, at the lower esophageal sphincter. It is smooth, elongated, no mucosal irregularity. This is what is called as the bird's beak sign of achalasia cardia. Well, I know a few eyebrows are going to go up because we have studied conventionally that rat tail appearance is being described in CA esophagus, right? That is true. But there are some books which have also mentioned that a smooth rat tail, right, without any mucosal irregularity may occasionally be seen in achalasia, whereas an irregular rat tail, right, has been described in CA esophagus. All right. So if you see here, look at this esophagus, you see an abrupt narrowing, and look at the diffuse irregularity along the wall of the esophagus. So this is what is, abrupt narrowing with mucosal irregularity. This is what would suggest CA esophagus. Now we come back to the question. Now see, football sign, there's absolutely no doubt about it. Football sign is seen in pneumoperitoneum. String sign here, remember, it is seen in hypertrophic pyloric stenosis. Although, remember, in literature, even in ileocecal TB, it has been seen. Inverted umbrella sign is specific for ileocecal TB, and we have seen rat tail sign, if it is irregular, may be seen in achalasia cardia. So the correct answer to this question is going to be the first one, that is football with pneumoperitoneum, string sign, pyloric stenosis, rat tail, achalasia cardia, inverted umbrella sign, ileocecal TB. All right, so this is just a match the following kind of a question. Now look at this interesting question. This was a CT scan based image. So what is this organ that you see on the right side of the abdomen, big organ? This is the liver, right? So patient has undergone a non-contrast CT, and this image in your exam was a non-contrast CT image, right? What is the most likely diagnosis? Now, why is this non-contrast? Is because look here, look at the aorta. We have discussed this, right? Look at the aorta. The aorta is appearing gray or isodense, so which means that it is lumen. There is no contrast, so this is a non-contrast image. Now, a few students have said that it was a very swirly, bright white appearing lesion within the liver. A few students say that it was a well-defined lesion with a very thick white rim around it. So for that purpose, I've actually put up both of these images here. Now, if you think of diagnosis of, focal hepatic lesions, remember that multiphasic contrast enhanced CT, the one that we take images in arterial phase, portal venous phase, delayed phase, is actually the investigation of choice for almost all focal liver regions, right? Is it possible, however, to make a diagnosis of a focal liver lesion on a non-contrast CT? For all focal liver lesions, what is the investigation of choice? We have discussed it is multiphasic contrast enhanced CT. What do we see on non-contrast CT? Tell me. On non-contrast CT, right? What can stand out, and appear different as compared to the adjacent soft tissues? One thing that can stand out and appear different is air. In what liver lesion would you see air? Air usually appears black or say hypodense on CT. Maybe liver abscesses may have some air specks within it that would give us a clue, but still we have to rely on the enhancement pattern of a liver abscess. So contrast enhanced CT would be the investigation of choice, right? What else could be seen on non-contrast CT is acute blood. Rarely blood would be found in focal liver lesions. Maybe hepatic adenoma can bleed. So at that time, this blood may appear as hyperdense, white area, bright appearing area within the liver lesion. Or very importantly, what can clinch the diagnosis, even on a non-contrast CT image, is the appearance of calcium or calcification, and this is something that would appear almost as white as bone in density. So look at these lesions, look at this hyperdense appearance, look at the adjacent rib. Can you see both of them are appearing hyperdense? Look at this dense hyperdense white appearing rim, and look at the appearance of the adjacent rib. Both of them are appearing hyperdense or bright white, isn't it? And this therefore tells me that this is a lesion which either has diffuse calcification within it or has a thick, dense calcific rim along its wall. And what liver lesion usually has this thick calcific white rim? It is a hydatid cyst. Remember the interesting animation that we saw about hydatid cyst, in which we looked at hydatid cyst as actually a story. And in that particular story, we actually looked at the various imaging signs in hydatid cyst. Let us quickly have a look at that particular animation. Now the various imaging signs in hydatid cyst, let us have a look at them. Now see, hydatid cyst begins as a simple cyst with clear fluid filled contents. At this time it appears as a simple cyst. It is indistinguishable from any other cyst. Now thick hydatid sand or hydatid debris appears within the cyst. These are mobile echogenic foci. So when the patient changes the position, even these echogenic foci may fall down to the dependent part. This looks like, this moving hydatid sand within the cyst looks like a snowstorm. So this has been called as the snowstorm sign of hydatid cyst. Now what happens? A hydatid cyst which is long standing in any particular organ usually may show thick peripheral wall calcification. We had discussed this, and this is exactly what was asked in your INI-CET exam. So any liver lesion, you see a thick peripheral curvilinear rim of calcification around it. This is what is a very peculiar feature of hepatic hydatid cysts, right? Now see, the innermost membrane of the hydatid cyst, that is the endocyst, is a very metabolically active layer, germinal layer. It divides and it creates daughter cysts within the mother cysts. So daughter cysts within a big mother cyst is another peculiar feature of hydatid cyst. The hydatid sand within the cyst may get trapped within these daughter cysts, and this trapped echogenic material has a spiculated appearance. This is what is called as the spoke wheel appearance or wheel spoke appearance of hydatid cyst. So this hydatid sand echogenic dense content trapped within these daughter cysts is called as wheel spoke pattern or spoke wheel pattern of hydatid cyst. Next, the entire mother cyst may completely get filled up completely with daughter cysts. So this is what creates your honeycomb appearance. So this looks like a honeycomb. So this is what is called as the honeycomb appearance of hydatid cyst. Now the inner endocyst wall layer may degenerate, and this degenerated membrane now starts actually floating within the cyst. This is called as the floating membrane sign of hydatid cyst. So this floating membrane within a big mother cyst, this is what is called as the floating membrane sign of hydatid cyst. Now if a hydatid cyst is within the lungs, what will happen? Air is going to enter the cyst, and this creates some peculiar appearances. Now, when a hydatid cyst enlarges in size, at some point, the wall of the hydatid cyst breaks and develops a communication with the bronchus. The air within the bronchus, enters the cyst wall. This air can get trapped within the cyst wall. This trapped air takes the shape of a crescent. So this creates a crescent of air in the trapped, in between the cyst wall layers. This is trapped air. So if it happens on the top of the cyst, it looks like a crescent. It can also happen at the bottom part of the cyst. When it happens on the bottom part of the cyst, this air is also trapped. So this looks like an inverse crescent. Sometimes air can just enter into the cyst or get scattered throughout its wall. Then various air bubbles can be seen within the cyst. When all the cyst wall layers rupture, what is going to happen? Air is going to enter into the cyst lumen, right? As a result, there are two air fluid levels which will become visible. One air fluid level, as you can see in this animation here, is located within the cyst walls, right? So this one that is within the cyst wall layers, that is the outer one. One air fluid level is located, within the cyst proper. These two air fluid levels are called combocine. When air enters into the cyst contents are also expectorated out. When that happens, the cyst membranes or the wall of the cyst can degenerate. These membranes, they form whorls or curls or swirls and start floating within the cyst cavity. This is what is called as the whorl sign or serpent sign of hydatid cyst. Some of these whorls or membranes may get arranged on the fluid surface within the cyst, take the shape of the petals of a flower, and this is what is called as the water lily sign of hydatid cyst. All these membranes may eventually get clumped together at the bottom of the cyst, and this is what is called as the mass within a cavity sign or the rising sun sign of hydatid cyst. So this is called rising sun sign or mass within a cavity appearance. Ultimately, this content may also be thrown out, then the cyst becomes completely empty. This is also given a name in hydatid cyst. This is what is called as the empty cyst sign of hydatid cyst. Now, whatever animations you've seen on the screen, we've tried to study it in the form of a story. Each and every animation that we have seen on the screen right now, right, is actually a named sign in hydatid cyst. I'm sure you've realized how important this is for your exam. We've just discussed this animation in the new, Marrow Edition 6 videos. And here is a question in your INI-CET exam on the same topic of hydatid cyst. Let us look at these signs now. Look at this CT image. You can see a simple cyst. Look at the yellow arrow there, simple cyst within the liver, right? At this point, it is indistinguishable from the other causes of simple cyst. Then I said, what happens? The hydatid sand is produced within the cyst. So this sand looks like these bright dots, like a snowstorm, right? These are mobile, echoes. When the patient changes the position, these echoes will fall down to the new dependent part. This is what is called as the snowstorm sign of hydatid cyst. Then a long-standing hydatid cyst, I said, what is going to happen? It is going to get calcified, right? This was the image which was given, similar image. So a liver lesion with thick, dense calcific rim around it, right? Around that liver lesion is very specific for hydatid cyst. This was the kind of image which was asked. If you see a big mother cyst and multiple daughter cysts within it, right? This is also peculiar of a hydatid cyst. So daughter cyst within a mother cyst. Thick content may get trapped in between the daughter cysts. This creates a wheel spoke or a spoke wheel kind of an appearance in hydatid cyst, right? Then what is going to happen is that the entire cyst may get completely filled up with daughter cysts. So this is what is called as the honeycomb sign of hydatid cyst, right? So this is the honeycomb sign of hydatid cyst. If a hydatid cyst is now this is what is when cysts are produced, right? But if the inner membrane gets degenerated, it may start floating within the cyst. You can see a big mother cyst and an enhancing floating membrane within it. This is called as the floating membrane sign of hydatid cyst. Now, if a hydatid cyst happens within the lung, what is going to happen? Air is going to come into the picture, right? So what will happen in such cases basically is that as the cyst enlarges, air is going to enter into the wall of the cyst. Can you see that black crescent on top of the cyst? This is what is called as the air crescent sign of hydatid cyst. Because this is trapped air, this can also happen not only on the top but also in the dependent part of the cyst. This creates an appearance which is called as the inverse crescent sign. Look at that cyst there. Can you see a crescent on its dependent or lower part? This is what is called inverse crescent. Air bubbles can be scattered throughout the cyst. This is what is called as the air bubble sign of hydatid cyst, right? When there are two air fluid levels, one outside, one within the lumen of the cyst, two air fluid levels is called as combocine. You can see membranes floating inside the cyst, right? When you see whorls of membranes floating within the cyst, this is what is given a name. This is what is called as the whorl sign or serpent sign of hydatid cyst. Few of these whorls or membranes may get arranged in the form of petals of a flower, right, on the surface of the fluid within the hydatid cyst, right? These petals of the flower create a classic appearance called as camelote sign or floating water lily sign. All these membranes may eventually get clumped down at the bottom of the cyst. These clumped membrane look like a mass within a cavity. So it is given a name. It is called as a mass within a cavity sign or a rising sun sign. Ultimately, this content is going to be expectorated out. The cyst will become completely empty, right? And this empty cyst is given a name. This is what is called as the empty cyst sign of hydatid cyst. So all these are named signs in hydatid cyst. So now if you look at this non-contrast CT image, right, you can see this calcific contents as well as a calcified wall along the right of the calcified wall of the cyst. So what is this? This is nothing but a hydatid cyst. Hepatocellular cancer is arterially enhancing lesion. You need a contrast enhanced CT for its diagnosis. Similarly, focal nodal hyperplasia, liver abscesses, all these focal liver lesions need contrast enhanced CT. Hydatid cyst does also need contrast enhanced CT, but on this non-contrast image, because of the calcification, we are able to make the diagnosis here. That is the clincher of this particular question. Yes. Now see here. An elderly female with curvature of the spine presents with abdominal pain and distension. She has this curvature deformity of the spine since childhood. This has been progressive. Based on the imaging findings, what is the diagnosis? I think what your examiner is doing here is the examiner is trying to distract you by taking your attention to this scoliosis. Can you see? There is a lateral curvature of the spine. So there is scoliosis. Some history about that scoliosis, but the examiner is actually trying to distract you. What is the most likely diagnosis here is that you are able to see two massively dilated loops. This is one, this is the other one, right? They are massively dilated loops. Can you see any hostrations along its wall? No, there are no hostrations along this wall. That is something that is going to clinch your diagnosis. Two dilated loops that you see in the abdomen, right, in an elderly patient, right, with pain in abdomen, right, and you do not see any haustral markings. What is your diagnosis? It is going to be a sigmoid volvulus, and that is what is the cause of, right, large bowel obstruction here. Now, what is sigmoid volvulus? Remember, sigmoid volvulus is actually a history clincher. What is that history clincher? We have discussed this. Look at this clinical scenario. So an elderly female, usually a known case of psychiatric illness. This history was not given over here in this particular question, but elderly female presents with massive gaseous distension of the abdomen with absolute constipation. And you see how many loops? Yes, 1 and 2. So total 2 dilated loops without any haustral markings, without any haustrations. This is the clincher of sigmoid volvulus. Various name signs have been described in sigmoid volvulus. So this dilated loops look like a coffee bean. It looks like an omega, right? It looks like a bent inner tube or a bent tire tube. So these are the various signs, right? Because the dilated loop is so massively dilated, it overlaps the liver here, it overlaps the flank here, it overlaps the pelvis here. So there are various overlap signs: liver overlap, pelvis overlap, flank overlap. Another peculiar sign is seen in sigmoid volvulus. What is that? It is called Freeman-Dahl sign. What is Freeman-Dahl sign? See, look at this wall. It would come here like this. This wall of the cyst would come here like this, right? And both these walls that lie alongside would come here like this. Can you see there are 3 lines converging where? At the site of the twist. So these 3 lines are actually converging at the site of the twist. When you see these 3 lines, this is what is called as the Freeman-Dahl sign of sigmoid volvulus. Volvulus means what? It is a twisting of a loop, isn't it? Which other part of the bowel can get twisted? Can you tell me? Yes, stomach can get twisted, but that is rare. So there is a gastric volvulus which has been reported. It is extremely rare. The second most common, part of the bowel to get twisted after the sigmoid colon is the cecum. So can we try and distinguish between a cecal volvulus and a sigmoid volvulus? Yes, let us try and do that. Age, is there a difference? Yes. So cecal volvulus is usually seen in the middle-aged patients, whereas sigmoid volvulus is usually seen in the elderly. Remember, as a part of the history clincher, we discussed this elderly patient, known case of psychiatric illness, pain in abdomen, distension, absolute constipation. Incidence? Yes, the most common part of the bowel to get twisted or undergo volvulus is sigmoid, right? This is the second most common part of the bowel to get twisted, that is the cecum. Hostrations, remember, we have already seen that in a sigmoid volvulus, hostrations are going to be absent, whereas in a cecal volvulus, the hostrations are always present, right? The hostrations are always present. See here, in this dilated loop, there are no hostrations which are seen in sigmoid volvulus. Look at the dilated loop of the cecum here. Can you see there are hostrations which are visible? So hostrations are present there. What about the other loops? What lies immediately proximal to the cecum? Small bowel loops. So can you see these dilated small bowel loops? Yes. So in cecal volvulus, you will see dilated small bowel loops, whereas in sigmoid volvulus, usually you do not see dilated loops. Occasionally, you may see the dilated descending colon and transverse colon that lies proximal to the sigmoid. So you may see dilated large bowel loops. And one very important point, key clincher that we have seen, how many dilated loops do you see in cecal volvulus? You see only one dilated loop, that is the cecum itself, whereas in sigmoid volvulus, you see two massively dilated loops. We've seen that multiple times today, right? So what is the diagnosis here? The diagnosis is large bowel obstruction due to sigmoid volvulus. You can see two dilated loops without hostrations with the typical coffee bean appearance which is seen here. So this is sigmoid volvulus. Yes. Now look at this. In a case of fungal pneumonia, which of the following findings may be seen? Now, honestly, I would say that this is an extremely theoretical question. I spoke to a lot of my friends, I spoke to a lot of my colleagues who have the ultimate expertise in reporting HRCTs, especially with infectious diseases, and each one of them agreed that the options that are being mentioned here are extremely theoretical. So if there's any question where there would be a little bit of controversy as to what the exact answer would be, it is going to be this particular question. Now, rather than going into the vagueness of this question and focusing there, let us look at some specifics about fungal pneumonia first and what could be seen in fungal pneumonia, and then we will come to the answer of this particular question. So fungal pneumonia can be caused by what? The most common agent that could cause fungal pneumonia is Aspergillus. Most commonly, it is going to be Aspergillus fumigatus. In immunocompromised patients, you may have candidal pneumonias, pneumocystis pneumonia, right? Whether you classify it as a fungus or a parasite, and mucormycosis. So these basically candida, pneumocystis, and mucormycosis, this is usually seen in a immunocompromised patient. Right, now let us start with the most important, most commonly encountered one, and that is aspergillosis. What are the various forms in which Aspergillus infection can actually present radiologically? It can present either as an aspergilloma, right? And if you see, this is a pre-existing cavity. Inside the pre-existing cavity, you see a fungal ball. It is in the dependent part of the cavity. So it is mobile. You change the patient position from supine to prone, right? This fungal ball will fall to the dependent part. And this black crescent of air here is actually called as monod sign. It is wrongly sometimes called as air crescent sign. Air crescent sign is not a feature of aspergilloma. It is the monod sign. Another allergic manifestation of Aspergillus infection is allergic bronchopulmonary aspergillosis, which is basically characterized by central bronchiectasis. Can you see all these dilated bronchi? Right? These are mainly central in location, isn't it? So centrally dilated bronchi, central bronchiectasis is a feature of allergic bronchopulmonary aspergillosis. Sometimes these dilated bronchi can get completely filled up with secretions, mucus, including fungal elements. So they may appear hyper dense or bright, right? So this creates a finger in glove appearance of allergic bronchopulmonary aspergillosis. Now, aspergillosis can also present in a vaso-invasive or an invasive type of aspergillosis, and that is the one which is the most dangerous type. It has very peculiar characteristic appearances. So this appearance is what is called as the halo sign. Can you see that there is a central dense area of consolidation, and surrounded there is a hazy area of ground glass opacity? So a central area of consolidation surrounded by a haze of ground glass opacity is what is called as halo sign, and this is because of the hemorrhage that occurs surrounding the necrotic part, right? So necrotic part is the consolidation, the hemorrhage creates the ground glass. This is called halo sign of invasive aspergillosis. When the central necrotic part undergoes cavitation because it is already dead, so it is sloughed off, there is a crescent of air. See, air appears black here, isn't it, on CT? So this crescent black this black crescentic appearance or air crescent is called as the air crescent sign of invasive aspergillosis, right? Now, sometimes, see, you can see another halo here. Can you see central consolidation and a ground glass around it? But you can also see some triangular peripheral wedge-shaped areas there. So some peripheral wedge-shaped consolidations, pleural effusions have also been described in invasive aspergillosis. In candidal infections, pleural effusion, this fluid can be tapped and then fungal elements can be observed in that particular pleural fluid. So it is also, though a rare, not a very classical appearance, a rare manifestations of fungal pneumonia. So if we come back to this, what have we seen? Have we seen a cavitatory lesion with surrounding ground glass opacity? Definitely yes. In the initial stages, it would appear as a halo sign. In the late stages, when it gets broken down or cavitated, it would appear as a air crescent sign, right? We have seen that. Will there be peripheral wedge-shaped consolidations? Yes, we have seen them. Will there be pleural effusions? Though it is not classic, it may be seen. What I did not find anywhere in any of the books is that there would be interlobular septations which have been described in fungal pneumonia. So according to me, the correct answer to this particular question is option A, that is peripheral wedge-shaped consolidations, pleural effusions, cavitatory lesions. Let me warn you again, this is a theoretical, a very vague kind of a question, and there could be some references which would say occasionally this and this would also be seen. I want you to not to waste a lot of your time on these options here. Don't break your head here. We have looked at some classic appearances: halo sign, air crescent sign, monod sign, right? Central bronchiectasis, finger in a glove appearance, right, of bronchoseals, right? So remember that is very important for your exams. Let us move on to something specific now, and this is something which is again an absolute favorite of your examiners. So child presents with cyanosis. What is this appearance? Can you see that this is the boot-shaped heart or a Coren Sabot appearance? For those of you who have a keen sense of sight, another finding here is a right-sided aortic arch. Almost 25 to 30% of children with tetralogy of Fallot have a right-sided aortic arch. So this is your boot-shaped appearance of tetralogy of Fallot, right? Now, see, tetralogy of Fallot, 4 important components: pulmonary stenosis, infundibular pulmonary stenosis, membranous VSD, overriding aorta, right ventricular hypertrophy. It is this right ventricular hypertrophy which is responsible for your boot-shaped heart or your Coren Sabot appearance, right? So oligemic lung fields, you can see the vascularity is very poor. Why? Because of pulmonary stenosis, blood supply is not going towards the lungs, right? So therefore there is going to be oligemic lung fields, right? And as we've discussed, a very high association with a right-sided aortic arch. So this is about tetralogy of Fallot, the imaging findings. Look at this normal appearance of the heart and look at this heart. Now, what is this? This looks like an egg, isn't it? So what is this? This appearance is nothing but your egg on side or egg on string appearance of transposition of great arteries or TGA. Now look at this classic appearance. This is a snowman's heart. So this is the head of the snowman. This is the body of the snowman. So this is the snowman's heart or figure of 8 heart, which is seen only and only in one type of total anomalous pulmonary venous return. And what is that? It is the supracardiac type, because this anomalous vein which goes up above the heart is what makes it supracardiac, and the head of the snowman is formed by this anomalous vein, right? So this figure of 8 heart, snowman heart, is seen only in one type of TAPVC or total anomalous pulmonary venous return, that is the supracardiac type. It is not seen in cardiac type, it is not seen in infracardiac type. Remember this. Very classic appearance in Epstein's anomaly is a box-shaped heart. So this is a box-shaped heart. Remember which chamber is massively enlarged in Epstein's anomaly. See here, what is this chamber? This is the right atrium. So massively dilated right atrium creates a shelf-like appearance of the right heart border. So this is what gives rise to a box-shaped heart due to excessive enlargement of the right atrium in Epstein's anomaly. Remember. All right. Now, yes, so this is about congenital heart disease. Now look at this. A 28-year-old female for severe headache comes for a CT scan. What specific history should you definitely ask before commencement of CT study? Another topic on which a lot of questions have been asked recently is radiation protection, radiation safety. A couple of years back, there was a question in one of the NEET PG exam saying that what will happen if you do a chest X-ray incidentally and then realize that the patient was actually pregnant? The radiation exposure in the chest X-ray is very low. A still lower level will reach the pelvis and irradiate the pregnancy, early pregnancy. So in such cases, all you do is you counsel the patient. It is not going to cause any significant harm. The patient can safely continue with the pregnancy. But to avoid this kind of a situation from arising, we must take some precautions beforehand. And therefore, when you do any X-ray based investigation, is there going to be radiation exposure in CT scan? Yes. Now, in a young female in the reproductive age group, you must always make sure that the patient is not pregnant. And what is the best way to do that? You ask her for her last menstrual period. If her last menstrual period is more than 1 month back, right, then you should be very cautious. Better do a urine pregnancy test first, urine UPT test first, and then you can proceed for the CT scan. So that is the simple logic. You want to avoid inadvertent radiation exposure to an undetected early pregnancy, and therefore you take these special precautions in young female. So that was the answer to this particular question. You specifically ask for her last menstrual period. Yes, so that was the answer. Okay, now see here another specific question. An HIV patient presents with headache and altered sensorium. Consider the following evidences about his condition. Which of the following is an absolute criteria for the diagnosis of neurocysticercosis? So very specific question. They've asked you not a definitive clinical diagnosis, but the absolute criterions. Now, what is this? Look at the options. Brain biopsy showing tinea solium, the causative agent of NCC. MRI showing the cyst with a dot sign. So you see a cyst and you see a small dot within it. That dot is the scolex of the parasite. It is specific for neurocysticercosis. CT showing ventriculomegaly with multiple periventricular calcifications. Now, some students have said that this, instead of CT, it was an MRI, but I wonder how calcifications would appear on MRI, because calcifications would be seen better on a CT. Typical nodular tiny calcifications in neurocysticercosis are seen, giving rise to the starry sky kind of an appearance. Over time, the NCC will get calcified. Muscle showing multiple focal calcifications. These calcifications is what is called as the rice grain calcifications. Now, though we've seen that all these, 4 options may be seen in neurocysticercosis, which of these is an absolute criteria? Well, this question specifically refers to the revised diagnostic criteria for neurocysticercosis, right? This was published in one of the Journal of Neurological Sciences. The question was about the absolute criteria, isn't it? So what was this? What are the absolute criteria? 1, histological demonstration of the parasite from a biopsy of a brain or a spinal cord lesion. This was one of the options, right? Direct visualization of the subretinal cysticercus. This was not there in your options. Conclusive demonstration of a scolex within a cystic lesion on neuroimaging studies. This was also an option. Now, radiologically, apart from the absolute criterions, there are some neuroimaging criteria which have been described. There are some major neuroimaging criteria. What are those? Cystic lesions without a scolex is a major criterion. Enhancing lesions, you remember, neurocysticercosis is a typically ring enhancing lesion, right? So NCC is a typical ring enhancing lesion. Multilobulated cystic lesions in the subarachnoid spaces in the racemose type of neurocysticercosis, and typical brain parenchymal calcifications. I told you, typical nodular calcifications, creates a starry sky kind of an appearance in a case of chronic neurocysticercosis. Some confirmatory neuroimaging criteria like resolution of the lesions after drug therapy, spontaneous resolution of a single small enhanced lesions, or migration of ventricular cyst on sequential studies are confirmatory criterions. Some minor criterions like obstructive hydrocephalus or basal leptomeningeal enhancement. Now, the question that was asked to you, apart from that, there are some clinical criterions which are also there. Usually, there is a typical combination of 1 absolute criteria or two major criteria, one confirmatory criteria, or two major criteria, one clinical criteria which is used for the final diagnosis. The question which was asked in your exam was very specific. It was about which of these is an absolute criteria for diagnosis. We have studied there were three criteria which were absolute. One, a brain biopsy showing the etiological agent, yes. MRI showing a typical skull exit appears as a cyst with a dot sign. And the third criteria was direct visualization of the cysticercus in the subretinal space. This was not there in the options. These are the absolute criteria. So the likely answer here is going to be D, that is option 1 and 2 here. This would be the answer. Now let us move on to the questions which were asked in session 2. Now see here, eggshell calcification is seen in all of the following except. Now what is this eggshell calcification? It is typically seen in lymph nodes, right? Lymph nodes in the chest, mainly in the hilar and perihilar paratracheal lymph nodes. Now look here, look at this chest x-ray. Can you see these round densities here? See, now can you see it well? All these round calcific densities are the eggshell calcification of the hilar lymph nodes, which is seen bilaterally. Can you see multiple ones? How would they appear on CT? Similar. See here, look at the arrows there. So this is again the typical egg-shaped eggshell calcification of lymph nodes. These are bilateral hilar lymph nodes. Right. Now, what are the causes of these eggshell calcification of lymph nodes? This was specific, the question which was asked. Now remember, there's a lot of calcium which is deposited on the nodes. Towards the periphery of the nodes, you can say there is a slab of calcium which is deposited, isn't it? So remember the mnemonic, slab of calcium. So S basically stands for silicosis, sarcoidosis, scleroderma. Right, so that is S, silicosis, sarcoidosis, scleroderma. L is lymphoma. But when in lymphoma? In lymphoma, eggshell calcification is usually seen post radiation therapy. Not at the primary presentation of lymphoma, but when these lymph nodes are treated with radiation therapy, right, then there is eggshell calcification which is seen. A is amyloidosis, which is a relatively rare cause of eggshell calcifications. B for blastomycosis and histoplasmosis, fungal infections. And C for an interstitial lung disease, that is coal workers pneumoconiosis. Right, so silicosis, sarcoidosis, slab of calcium. Remember, silicosis, sarcoidosis, scleroderma. L is for lymphoma, that is post-radiation therapy, amyloidosis, blastomycosis, histoplasmosis, and calcium is coal workers pneumoconiosis. So if we look at this question now, see, eggshell calcification is seen in all of the following except silicosis it is seen, sarcoidosis it is seen, post-radiation therapy lymph nodes it is seen. It is not seen in metastatic lymph nodes, right? So that is going to be the answer to this particular question. Fairly straightforward question. Now see here, 55-year-old man, so elderly man, presents with what? Presents with painless hematuria. Contrast enhanced CT reveals a mass lesion in the right kidney. So see, this is a contrast enhanced CT. Look at the aorta, it is appearing hyper dense. This is the right kidney. See, a heterogeneously enhancing mass lesion in the right kidney. The left kidney looks normal. Now remember, this is a history clincher. What is that? Elderly male with painless hematuria with a renal mass is renal cell carcinoma, RCC, unless it is proven otherwise. Elderly male, painless hematuria with a contrast enhanced CT is an RCC. So painless gross hematuria in an adult with a mass lesion in the right kidney. See here in the non-contrast CT, it is heterogeneously enhancing there. You can see the exophytic heterogeneously enhancing mass lesion on a coronal reconstructed image. This is renal cell cancer. What is the overall investigation of choice for renal cell cancer? It is, remember, contrast enhanced CT. Whereas if they specifically ask you the investigation of choice in a case of RCC to look for renal vein invasion, so RCC has a very peculiar method of spread, and that is it can go into the renal vein. From the renal vein, it can go into the IVC as well. right? So to look for this vascular extension or invasion, the investigation of choice is contrast enhanced MRI. It is contrast enhanced MRI. So overall investigation of choice, if they ask you, it is CET. If they specifically poke you and ask you for vascular invasion, it is going to be contrast enhanced MRI. Now let us quickly look at some renal focal lesions. If you see a bright appearing, hyperechoic appearing renal lesion on USG, and if you see a heterogeneously appearing lesion on CT, which enhances heterogeneously, but look at this central density. What is this density? It is fat density. If you see fat density, it looks similar to a peritoneal fat as well as subcutaneous fat, isn't it? So if you see fat density within a renal lesion, it is angiomyolipoma. What is angiomyolipoma? Angio means vascular tissue, so it is going to enhance. Myo means smooth muscle tissue, and lipoma means what? Macroscopic fat. So this appearance of fat density within the lesion is going to clinch the diagnosis of it being a renal angiomyolipoma. Renal angiomyolipoma is associated with a neurocutaneous syndrome. Can you tell me what is that? It is tuberous sclerosis. So it is commonly seen in tuberous sclerosis, where patient may present with multiple renal angiomyolipomas at a very young age. Renal oncocytoma is basically indistinguishable from an RCC, right? On imaging, it is a benign lesion, but it has a very peculiar feature. And what is that? It is this central stellate non-enhancing scar. So if you see a renal lesion with a central scar, right, it may be an oncocytoma, but that is an histopathological level distinction which is made. Otherwise, imaging wise, it is very similar to a RCC. Yes, so in this elderly man who presents with painless hematuria, right, contrast enhanced CT has revealed this heterogeneous mass lesion. So the answer is going to be RCC unless it is proven otherwise. So whole body CT scan done for trauma includes all except, what does it not include? It does not include the limbs. Cervical spine is included, head is included, abdomen is also included. So this was about whole body CT. A 34-week primigravida is detected to have intrauterine fetal demise. So unfortunate. The finding of hyperechoic air specks within the blood vessels is known as what? Now, what is the most definitive way to diagnose intrauterine fetal demise? It is to do a real-time USG along with a Doppler, right, and demonstrate that there is no cardiac activity, right? So that is how we definitively diagnose intrauterine fetal demise. Now, many times this goes undetected for some duration, and the patient turns up for a routine scan or a routine follow-up. The obstetrician is not able to trace the cardiac activity, auscultatory cardiac activity demonstrated. So the patient is sent for a scan. Patient has no complaints at all, but the actual event has happened a few days back, and then some imaging signs are basically seen. Traditionally, these have been described. So what is the definitive way to diagnose intrauterine fetal demise? It is absent fetal cardiac activity in utero. This can very readily be demonstrated on real-time ultrasound along with Doppler. Now, as the brain gets macerated, the brain shrinks. So the cranial bones significantly overlap over one another. This is what is called as the Spaulding sign, which is seen in intrauterine fetal demise. Maybe as a cause of fetal demise, or sometimes as a sequel of fetal demise, the fetus becomes hydropic. This is called fetal hydrops, which means what? Excess of fluid. Hydro means what? Fluid. So excessive fluid collections in the skin and subcutaneous plane. Look along the head. There is the skin and subcutaneous plane is thickened. Look along the thorax, it is thickened. There is fluid within the pleural and pericardial cavities. There is excessive fluid within the fetal abdomen, ascites. So all this suggests fetal hydrops. This is also a feature of IUFT. Now, suppose, see, look at this twin pregnancy. First twin was normal, but the second twin, had a fetal demise, right? A few weeks back. What is going to happen? The second twin is going to shrink. It is going to be pushed to one corner gradually. The live viable pregnancy is going to compress, the dead twin, and it is going to get macerated. It is going to shrink. So this is maceration is also considered to be a feature of intrauterine fetal demise. And then as time passes, these hyperechoic air specks, they develop within the heart, within the blood vessels, that is the neck blood vessels here. and this is what is called as the Robert sign of intrauterine fetal device. So this hyperechoic air specks within the blood vessels is what is called as the Robert sign. This was the answer to this particular question. Now look at this very peculiar image. This 99M methyl diphosphonate bone scan done in a patient of prostate cancer with elevated serum PSA level is due to what? So prostate cancer has a propensity to spread to the bones, especially the axial skeleton. The metastasis in the vertebral column or the bones in prostate cancer is usually osteoblastic type, where excessive bone production occurs. And if in CA prostate along with METs, we do the tumor marker. What is the tumor marker for prostate cancer? It is serum prostate specific antigen PSA. It is going to be elevated. So what is this image? This is a radionuclide image. We have injected a 99M technetium methyl diphosphonate. It is the investigation of choice for detection of skeletal metastasis. So investigation of choice for detection of skeletal metastasis is technetium 99M technetium MDP bone scan. Now there's going to be a lot of uptake of this methyl diphosphonate at the site of bone mets. So these bone mets are going to appear as hot spots or increased uptake, right? So look at this image. This is a inverted image where all these black areas that you see are the site of excessive uptake of the methyl diphosphonate. So where do you see this excessive uptake? You see it basically in the central axial skeleton, the hip girdle, right? The shoulder girdle as well. Now the uptake is, this is such a super uptake of MDP. I'm giving you a clue. This is such a super uptake of this MDP into the axial skeleton that how is MDP excreted from the body? It is excreted through the kidneys. Can you see any uptake in the kidneys, in the lumbar regions there? No. Can you see any, MDP compound within the urinary bladder? No. So when there is excessive uptake of this technetium labeled MDP into the axial skeleton because of the metastasis, this is such a super uptake that there is no excretion through the kidneys and the bladder. This is what is called as a super scan, and we've discussed this in our routine edition 5, edition 6 videos. What is a super scan? Excessive uptake within the bones of the axial skeleton, right, without any excretion through the kidneys and the bladder. This is what is called a super scan. And in the case of CA prostate, right, so it is going to be excessive skeletal metastasis. Most common cause of a super scan is, remember, CA prostate. After CA prostate, lung cancers, cervical cancers, endometrial cancers can also give rise to a super scan. There are some non-neoplastic causes of super scans as well, like some metabolic conditions such as hyperparathyroidism, renal osteodystrophy, Paget's disease can also give rise to super scan occasionally, right? Certain, bone marrow related conditions such as myelofibrosis, leukemias, lymphomas can also give rise to, right, super scan like appearance. So in this patient who is a known case of prostate cancer with elevated serum PSA, it's excessive uptake in the axial skeleton without any renal excretion or excretion through the bladder, is because of diffusely increased uptake of MDP within the skeletal metastasis. That is the cause for this excessive uptake. Yes. Identify the highlighted liver segment here, segment 5, 6, 7, 8. Well, what are they referring to? They are referring to the functional anatomy of the liver, or segmental anatomy, or Coinod classification. Now, basically, what are the structures that, demarcate the liver into different lobes and segments? We'll discuss this. Remember, liver is classified into two lobes, left lobe, right lobe. left lobes has segment 1, 2, 3 and 4. Right lobe has segments 5, 6, 7 and 8. Okay, that is a brief introduction. Now let us have a look. Where is lobe 1 located? 1 is the caudate lobe. It is located extremely posteriorly, right, just in front of the IVC. It is not seen from this frontal depiction here. It is the extreme posterior lobe, just enter to the IVC. It has separate venous drainage into the IVC as well. So that is lobe number 1. Now, what are the structures? Remember, whenever you're trying to divide the liver, you must always look for 3 structures. 1, look for the hepatic veins. 2, look for the portal vein and its branches. And 3, when you're dealing with the left lobe, you look for the falciform ligament. Now see, there are 3 hepatic veins we know. Right hepatic vein, this is the middle hepatic vein, this is the left hepatic vein. So the middle hepatic vein, remember, divides the liver. If I draw a line along the middle hepatic vein, divides the liver into the right lobe on one side, that is its right, and the left lobe on its left. Now each of these lobes is divided into an upper part and a lower part by the branches of the portal vein. So the part of the liver that lies above the right portal vein branch would be the upper segments, below it will be the lower segments. Similarly, left portal vein branch will divide the left lobe of liver into upper segments, lower segments. Yes, is it clear? So 3 important structures we must always see. Hepatic veins, we've just seen. Middle hepatic vein divides the liver into right and left. Portal vein, right and left branches will divide each of these lobes into the superior segments, inferior segments. And the falciform ligament, when we deal with the left lobe, how do we look at the falciform ligament and its plane? I'll come to that. Now look at the schematic diagram. Now do you remember I told you it is the middle hepatic vein that divides the liver into the right lobe and the left lobe. Now let us focus on the left lobe first. I've told you segment 1 is located posteriorly here. See, just in front of the IVC, it won't be seen from the front. That is a separate segment. What is this? This is the caudate lobe. Now, the rest of the left lobe, let us have a look. Now, a few theories says that it is the left hepatic vein that divides the left lobe of liver into the part, into the medial part and the lateral part. A few books say that it is actually the falciform ligament, right? Falciform ligament and its plane passing from the falciform ligament to the IVC that divide the left lobe into the medial and lateral part. The one that lies, to the left of this plane is segment 2 and 3. How is it divided? Superior and inferior. What divides the left lobe into superior and inferior? We have discussed this. It is the left branch of the portal vein. Can you see here? So the middle hepatic vein divides the liver into right and left. In the left lobe, it is either the left hepatic vein or the plane connecting the falciform ligament to the IVC that divides it into, the medial and the lateral part. To the left of this plane, superiorly above the left branch of the portal vein is segment 2. Below the left branch of the portal vein is segment 3. Similarly, to the right of this particular plane, above the level of the left branch of the portal vein, you have segment 4A, right? Below the level of the left branch of portal vein, you have segment 4B. To the right of this, now, to the right of the middle hepatic vein here, you have the right lobe of liver. The right hepatic vein divides it into the anterior parts and the posterior part. Each of this anterior part and posterior part is divided further by the right branch of the portal vein into superior and inferior parts. So look at this. In between the middle hepatic vein and the right hepatic vein lies the anterior part of the right lobe of liver. The upper part of it, that is the part that lies above the right branch of the portal vein, is segment 8. Below it is segment 5. The posterior part of the right lobe of liver lies behind the right hepatic vein. The upper part above the level of the right branch of the portal vein is segment 7. Below it is segment 6. Can you see that? Let us look at this on a CT actually now. Now see here. These are all contrast and on-CT images. Why? Because what should we look for on a CT scan whenever you are trying to identify lobes? 1 hepatic vein, 2 whether portal vein is seen or not, and what is the level of the falciform ligament. So here if you see, portal vein is not seen. Okay, now here this is the aorta, this is the IVC. So what is this? This is a segment that lies just in front of the IVC. So this is segment 1. What is that? It is nothing but the caudate lobe. Now if you see here, look at these images, the first image and the second image. If you watch carefully in the first image, now see, we are at a higher level. In the first image, you are not able to see the portal vein. You can see the aorta, you can see the IVC. This is the right hepatic vein, this is the middle hepatic vein, this is the area of the left hepatic vein. You're seeing a part of the liver which is to the left of the left hepatic vein, and superiorly. Why? Because the portal vein is not yet seen, portal vein branches are not seen. So what is this segment? This is going to be segment number 2. Look at this. Again, you're at the more or less corresponding site, but here can you see the portal vein which is going into the porta hepatis? So we are at a lower level. So just below segment 2, you will have segment number 3. So these are parts of the left lobe of liver. Now we come here. If you see again in this image, you can see the aorta, you can see the IVC, you can see the right hepatic vein, middle hepatic vein, left hepatic vein. Can you see this colored part is between the middle hepatic vein and the left hepatic vein, and portal vein is not seen, so it is at a higher level, isn't it? Right. So what is this? This is a part of the left lobe that lies to the right of the left hepatic vein. So this is segment 4A. The same part lies at a lower level, right? Because here the portal vein is seen, it is at a lower level. So this is going to be segment 4B, right? Now see here, this is the right hepatic vein, this is the middle hepatic vein, right? This is the left hepatic vein. So this part of the highlighted part lies between the middle hepatic vein and the right hepatic vein. So it is to the right of the middle hepatic vein. This is a part of the right lobe. Portal vein is not seen, so it is the superior part. So superior part, right lobe between the middle hepatic and right hepatic vein is segment 8. Just below segment 8 in the same corresponding area, but below, because portal vein branch is seen here, this is going to be segment 5. These are the anterior parts of the right hepatic lobe. Now similarly, if you see, this is right hepatic vein, middle hepatic vein, left hepatic vein there, right? So this is a posterior part of the right lobe, a part that lies to the right or posterior to the right hepatic vein, superiorly, because portal vein branches are not seen. So this is going to be segment 7, and just below it, it is going to be the segment 6. So these are the various lobes. Now if you see here, look at this image. This is the aorta, this is the IVC, right? This is the right hepatic vein, this is the middle hepatic vein, this is the left hepatic vein. The highlighted part lies between the middle hepatic vein to its right, and in between the middle hepatic vein and the right hepatic vein, superiorly, because portal vein branch is not yet seen. So this is the anterior part of the right lobe of liver, superiorly above the level of the portal vein. So what is this? This is going to be segment number 8. So the answer here is segment number 8. So this was a question based on segmental liver anatomy with a little bit of practice. And if you look at, try to identify the hepatic veins, portal vein, right? Now this is something that will help you demarcate the various segments well. Well, friends, remember that we started this particular session by saying that we must continue to learn. We must continue to, learn some new things, because you must have realized that in these particular, questions, there were some new topics which were asked. Who knows, one of these topics would be repeated straight away in your upcoming exams. So the key to success, remember friends, is to keep on learning beyond what you already know. A little bit of new learning every day as you approach towards the exam, is very important. And ultimately, whatever you read, whatever you learn, remember the most important thing is to, after all, revise it. Because what you revise, you're going to retain well, in your heads. There's going to be a memory area, designated, a file which is going to be created in your brain that is going to be stored into it. If you go into your exams and you see a question on the same particular topic, your brain is an efficient computer. It will go to that particular folder, subfolder, pick up that file, open it, and there it is in front of you. You'll get the answer to that particular question. Our aim of conducting all these recall sessions here is to give you all the information that you need to know about all these important topics and recently asked questions as you go into your exams. And this is going to help you get that particular great score and a great rank so that you get their dream postgraduate seat. Let us all do this together. All the best.